Good afternoon, and thanks to the organizers for giving this chance. I will be discussing two papers. Now, we have been discussing all the adjuvant therapy and when to do surgery and all. Now we are jumping straight to CRPC. So what I will be talking is two studies in CRPC. Now, in metastatic CRPC, there is data in the second line of using the PARP inhibitors. So that data was for the second line. So logical conclusion to anything when medical oncologists find something working is we try to push it further and further. Already the data has come now in the first line, and now I'm sure in the future there are trials in the HSPC. We are going to push it even further if possible. Right, so there are 3 trials in the first line combination of a PARP inhibitor and an ARPI. Now this terminology keeps changing depending on who uses it. You can call it an androgen receptor pathway inhibitor, you can call it an androgen receptor steroid inhibitor, you can call it whatever you want, but this is essentially the group of drugs which are all targeting the androgen pathway. So you have the abiraterone, enzalutamide, darolutamide, all of these for this setting. Right? So there are 3 studies which have been done. One is the PROpel study, the TALAPRO-2 study, and the Magnitude study. Magnitude, I have kept it separately. It's with niraparib, which is really not available in India, so we could possibly ignore it. TALAPRO-2 is talazoparib, which again we do not have right now, but we would expect to get it in some time. The PROpel is with the olaparib, which again all of us are rather familiar with. Right? So why combine these two? That's the first question. Now, remember the PARP inhibitors usually work for DNA damage. Now, when the DNA damage occurs, there is a DNA repair mechanism which includes both the androgen receptor as well as the PARP, the PARP. Now, this PARP, if we inhibit and at the same time we block the AR as well, both of these will not allow DNA repair to occur. Once the DNA repair is not there, in the tumor cells, this will increase the efficacy of anti-cancer therapy. That's the logic behind using this combination. So again, as we will see, the doubt always comes, would you use a PARP inhibitor only where you expect it to work? For example, in a homologous repair deficient area, would you also expect it to work in a homologous proficient area? Now that discussion is why they have added this ARPI to a PARP inhibitor so that it will work in both the settings. That's the idea. So this is a phase 3 study, TALAPRO-2, first line talazoparib and enzalutamide in metastatic CRPC. So essentially enzalutamide alone is a standard of care for CRPC, and talazoparib is a potent PARP inhibitor preventing DNA repair. Now there's a phase 2 study which showed that if you used it in CRPC patients with HRR gene alterations, so HRR again is homologous repair pathway. Should you use it in all the 15 genes which one trial used? Should you use it only for BRCA1, BRCA2? ATM should use it? These are questions which have been debated endlessly in the last 3-4 years. My take on it is it works only in BRCA1, BRCA2. Possibly it might work if you in ATM. The other HRR really doesn't work. That's my take on it. So the TALAPRO-2 was a trial which evaluated talazoparib and enzalutamide. In these patients, they did not select for HRR status here. So that's the important point. HRR unselected patients. Randomized double-blinded, they stratified by prior abiraterone, prior docetaxel usage for castrate-sensitive prostate cancer. Again, in HSPC nowadays we are using docetaxel, we are using abiraterone for a lot of patients. So this was stratified, whether this was you given or not. HRR gene status, deficient versus proficient. Now, interestingly, they did try and prospectively assess the patients for these mutations. Then, the gene mutations they have used. Again, I spoke to you about the 14, 15, whatever number people check. They looked at BRCA1, BRCA2, PALB2, ATM, ATR, CHEK2, and other 3, 4. Does a PARP inhibitor work in all of them? Other than BRCA1, BRCA2, possibly ATM, the data is unclear. So then they used talazoparib with enzalutamide, placebo with enzalutamide. Primary endpoint, radiological PFS. Again, we are not looking at a biochemical, we are looking at a radiological PFS. How many of us would continue doing a scan in a CRPC? Most of us wouldn't, but still this trial looked at that radiological PFS with a key secondary endpoint of overall survival. So these were the baseline characteristics. Now I've highlighted the ones which are very important, that is prior abiraterone or docetaxel usage was in 27% of patients. 73% did not use it. 27% of which 5 were abiraterone, 21 were docetaxel. In HSPC, at least anecdotally, I think in India, most patients do go on to abiraterone rather than docetaxel, but their study more were on docetaxel. What about HRR gene status? HRR deficiency was seen only in 21% of patients. All the remaining were either non-deficient or unknown. Again, important because that is a stratification factor for this. What was the result? The talazoparib enzalutamide arm was not reported versus 22 months in the placebo arm. So CRPC first-line enzalutamide 22 months is quite good. I mean, it's actually more than what the original trial would have reported. 22 months there, the hazard ratio 0.63. So we need to keep an eye on these HRRs. The hazard ratio is 0.63, median RFS. Look at the HRR status. So HRR deficient, it's 0.46. HRR non-deficient is 0.66 or unknown 0.7. So this is the number we need to remember. 0.63 is a headline number. The one which really benefits is this 0.46. So if you have a HRR deficient, that is where I would like to use my PARP inhibitor. But remember, the trial has not included a third arm of only a PARP inhibitor. So does PARP add anything to enzalutamide? Is enzalutamide adding anything to talazoparib in the HRR deficient group? We don't know. That is not included in this study. Looking at the median overall survival. Now, very interesting. I was not able to explain this. When you look at the median RFS, it is not reported for the entire group, but the median OS has been reported. I really want to look at the events and number of events to understand this. They had enough median overall survival events to give you a median OS here, but did not have enough events to give you a median PFS. I am not sure how that works. I really need to look into the final paper when it's published, but be as it may, when you look at the overall survival, 36 for the talazo, not reported for the other arm, yet the hazard ratio is 0.89 in favor of talazoparib. Crossing the unity, p-value all over the place. So overall survival not met. Following the trend of almost all PARP inhibitors in prostate, overall survival benefit is not seen even with the talazoparib. So that is something we need to remember. Right. Now what about other efficacy outcomes? You have response rate, the CR rate is 37%, which is rather astounding when you look at the combination. But again, if that CR is not translating into an overall survival and an RPFS which is just there, I'm not sure what significance it has. Serious adverse events, again, I'm not looking at everything because in a trial you get much higher adverse event related, but treatment related serious adverse events of 20%, it's not something we can ignore, especially when you're combining two drugs together. So again, looking at the major side effects, anemia, thrombocytopenia and fatigue. So their conclusion was that this significantly improves the RPFS as compared to this, and a clinically meaningful RPFS improvement in all comers, benefit with and without HRR gene mutations. So I'm saying it's their interpretation. Personally, I'm still okay to use this in a group which has got HRR deficiency. If it's HRR proficient with a 0.7 HR, with a no OS advantage, in fact a slightly lower OS, I am not sure this is the right drug for this combination. So I think we are given 15 minutes. I think your stopping clock in 10 minutes. It's 15 minutes. Yeah. So the investigators concluded that the trial supported the use of talazo and enzalutamide. I would personally not really agree with this. Again, the reason why, when you have another trial, the PROpel analysis. Now, PROpel looked at abiraterone and olaparib versus abiraterone and placebo. Again, remember, there's no third arm here, right? This is what I've been saying. There's no third arm. You do not have a olaparib alone arm. You have now the reports of abiraterone and enzalutamide in the first line CRPC, which gives you an overall survival. Look at these numbers, 34 and 35 months. Remember the previous trial? The enzalutamide did not have an overall survival not reported in that trial. So, these are the numbers we are going to look at. Proof of concept was there from a phase 2 trial, which said that it is better RPFS. Obviously, we like a phase 3. Again, this is the phase 3, almost the same as what was there in the TALAPRO trial. You could use other NHAs other than abiraterone if they were stopped 12 months in advance. So that was something seen differently from the previous study. They allowed abiraterone in 5% of patients. Abiraterone 1000 mg olaparib versus abiraterone alone. Key secondary endpoint, again, RPFS, right? So the data again, previous docetaxel treatment 22%. TALAPRO-2 had 21%, almost the same. Looking at the HRR mutated, 27.8, Previous study, 25%. So you have very two similar studies looking at what you're seeing. And when you look at the RPFS, 24.8 versus 16.5 with a hazard ratio of 0.66 overall. Previous study, remember, it was 0.63. So in effect, abiraterone plus olaparib, enzalutamide plus talazoparib. The drugs are similar. The results seem to be similar. When you have a BICR, that is a blinded review, it's coming down to 0.61. Now, the interesting thing comes about when you look at the HRR mutant and the non-HRR. HRR mutant 0.5, talazoparib 0.43, 0.76 for the non-HRR, there it was 0.71. So, essentially similar results. Good thing really is for the BRCA mutant. There it is 0.23. And again underscores the point, in prostate, if you want to target something with a PARP inhibitor, it's the BRCA that you should target. Anything non-BRCA, the results are really not favoring you in any way. Whether you combine an NSA with it, you give it however you want, somehow the benefit seems to be driven by this BRCA mutant subset. What about the overall survival? And again, like TALAPRO had an initial overall survival which was not met with a hazard ratio of 0.85, here it's 0.91, touching the unity of 1 and the p-value of 0.0544, which is beyond the boundary. It's only 48% maturity. Yes, you can look at this graph and hope that that trial, that the curves keep separating, but honestly, I am not very convinced with this data that it is actually going to give you an overall survival advantage. Results with OS across subgroups, again, looking at the hazard ratio, the HRR mutant group, 0.68, HRR non-mutant, again, 0.89, non-significant. BRCA mutant, 0.29, non-BRCA, 0.91, which is non-significant. So what about, again, they have looked at this OS overall in the HRR mutant subgroup, 48 events with a median overall survival not reported, hazard ratio of 0.66. In the non-HRR mutant, it is 42 versus 39, 0.89, non-significant. So again, if you do not have a HRR mutant, this combination, or any combination for that matter, does not really seem to work. I'm sure my moderator will be discussing this point, but this seems to be the consistent results. If you have a BRCA2, it will work. You have a HRR non-BRCA, the benefit is doubtful. You have neither, it's practically not of any use. Yes, you have secondary endpoints, TFSP, PFS2, all showing 0.76, 0.78, all these numbers are there on the paper, but again, for me, the headline numbers are what matter, and those headline numbers simply don't match up to me. Looking at the AEs, death due to AE is around 6 and 5, so similar. Dose interruptions and discontinuations are higher in the olaparib, it's 17% and 19% in the previous arm. Most common AEs, as expected, anemia, fatigue, and thrombocytopenia. Quality of life, surprisingly, like all medical oncology trials, quality of life never matters even if you keep pumping them with extra drugs. The HR quality of life is always similar. Take it with whatever you want. So again, the conclusions of the author that the PROpel met its primary endpoint, demonstrating a significant and clinically meaningful RPFS benefit. Median benefit is around 7 months overall. The OS is only a trend which was sustained but not significant. The combination is better by around 7 months, but finally not something that you're having a significance for. Now this was the magnitude study. Remember I told you the third study, niraparib abiraterone. Look at the numbers, 0.53, RPFS 0.73. In the BRCA 1 and 2, it's 0.5, otherwise it's 0.73. This is exactly the same as what we have seen in the previous two studies. Overall survival, 0.94, again crossing your unity. So none of the three trials have demonstrated any overall survival. So I have not actually had the time to load the last slide, which is today morning's breaking news as given by our good friend Dr. Amol Akhade in his WhatsApp group. So there is the ODAC committee, which for the FDA, which has not given permission for this, has not given approval for the combination in all comers. It has approved the combination only for BRCA1 and BRCA2 mutant groups. Otherwise, no other patient should get this combination. And that's what I would also agree. PARP inhibitors are here to say, but benefit is only in the BRCA mutant subgroup. Other HRR, not so much. Only RPFS benefit, OS benefit is very, very questionable. Second, third line, I'm okay to give a monotherapy with either olaparib or rucaparib, but that again is in BRCA 1 and 2. In ATM, well, I could make a case for it. Any other combination, any other usage is still experimental at this point of time. So, thank you.